So we will be reviewing the acronym and 10 practice questions along with that. And the first level of the acronym is safety, which involves any consideration of abuse, neglect, harm to self, harm to others, substance use, medical, or a mixture of all of it, or psychosis. And a lot of people sweep that under the rug and say that's a part of the assessment phase. But the mental status is very, very important along with this, because if someone is not able to consent or they're not in the right mind or oriented times four, it could be preventing them from being able to engage, or a safety issue for us or for them or for everyone around them, depending on what's going on. So we always want to gather more information when we are unsure about the situation, because if we don't have the information, we can't add it into our considerations. And when you're looking at practice questions or looking at exam questions in general, a lot of times if the information's not on the page, you don't want to add it into the question, because that could be very detrimental to everyone, if not us. So don't add anything to the question that isn't there. And also, we don't assume, because if we assume things, it makes a butt out of you and me, because we don't want to jump to conclusions, do things that are not within our wheelhouse or what we can actually do. So do not investigate the issue when it comes to any aspects of safety, but investigation does not mean that we don't gather more information. Investigation means that we don't take it upon ourselves to do all the grunt work to figure out what the heck's going on. So we do assess, which is us gathering more information, but we don't investigate, which involves gathering further information. So the common considerations that we'll see here is abuse and neglect. So it can be child abuse and neglect, which involves anyone from the ages of newborn, aka 1 second, to 18 years old, or if someone has a cognitive disability, then they fall into this as well. So this can be physical, mental, emotional, sexual, and or all of them mixed in together, or just a couple of them mixed together as well. So it could look different for each thing, but if there are signs of the abuse happening, such as child falling asleep in school, excessive aggression, absences, dirty clothing, inappropriate sexual behaviors that they're doing onto other people, playing with toys and acting out the sexual behaviors, etc., then you would want to assess and address and do all of those things to make sure that there is not actually a safety concern. So the telltale, if you think it's a suspicion, then you have to do something. And neglect is any aspect of their basic needs being unmet: shelter, food, transportation, supervision, clothing, etc. And if we have the possibility, we want to go to the child if they are of age and able to communicate their issues. So I would say anyone older from 4 or older, because if they're less than 4, they're probably not aware of what is actually going on with and for their situation, and they don't have that cognitive processing of being able to tell us. But if that is the case, then we need to observe it. So if in doubt, assess. And it can also be adult abuse. And this is anyone from 65 or older, or anyone who has a developmental or cognitive disability, as I said before, because if people are not able to account for themselves, then we have to intercede and protect as needed. And this can be physical, mental, emotional, sexual. And I add financial into here because most kids aren't getting cashed out money, so they can't necessarily get exploited in some way financially. But if they are getting like child support and stuff, but I digress because that is a little more in depth. And it can also be neglect. It looks a little bit different for adults being neglected, but same considerations: food, shelter, transportation. And I add connection into here because most kids, they are getting that social connection, but adults, if they aren't able to get outside of the home, or they are in a facility and they're not getting that social connection as they would without the restraints within their situation, then we would need to intercede as well. And then financial, as I said, is a consideration as well. So if there is abuse and neglect, there is 1 or 2 possibilities that we are going to see as considerations. So the first one, if someone other than the person tells us about the abuse and neglect, so teacher, parent, friend, colleague, coach, pastor, concerned citizen, etc., tells us, then we need to gather more information, aka go into the person if we can communicate with them before filing a report, because again, we don't want any hearsay, we don't want assumptions, we don't want third-hand information. So we need to ensure we have enough information before proceeding. We need to have enough information to be able to relay the information. So if someone tells you third-hand information and you're filing a CPS report or APS report, They're going to ask you who the person is, where they're at, what's the situation, etc. And if you don't have all that, it's kind of hard to file a report. So we do not want to make blanket statements, or we don't want to report hearsay at all. So you want to do your due diligence and assess the situation prior to ignoring and or proceeding in some way. And then the other consideration, if it is not someone other than the person, it's the person. So if someone is being abused or neglected and they tell us directly, or if the person that is doing the abusing or neglecting tells us, then we can report it immediately. Why? That is firsthand information, and we need to run with it and protect. So we hear directly from the person. It would not be considered hearsay. Why? Because we heard it from the horse's mouth. So let's get on. So if the person is not of age of being able to communicate, as I said, around 4 or maybe 3 or older, we can base it off a decent amount of observation. So if you watch how someone interacts with other people or what they do in their current situation, you're going to be able to say, wow, that person is not able to socialize adequately, or that person is a little more aggressive, etc. But again, we always want to assess the situation, but do not want to investigate in some way. And then medical concerns, it can be a physical or health concern or physical harm done to the person. So, for example, we have someone who has a broken arm in session. We have to have them have medical services rather than proceeding. We're not going to have someone's arm dangling at the side of them while we're communicating with them, because they're not even thinking about the moment right now. They're thinking about their arm dangling, and we need to help them in some way. So if there is a medical concern, we'd want to assess and figure out what the client wants. But at the end of the day, even if they're not willing to get that, we have to document that they're doing AMA against medical advice. But we always want to assess and consider that as well, because sometimes physical conditions can mimic psychosis as well as other safety considerations and etc. It could also be their physical health, like changes of physical health within our offices as well. So a big one, drug withdrawal. So if someone's withdrawing, they are going to have some physiological sensations or reactions in some way. So if someone is in our office sweating, nodding out, and struggling to breathe, I'm not just going to be like, well, you must be just really tired, and our topic is getting pretty heated, so you must be reacting in an inadequate way. No, bad moves, bad vibes. We need to suggest they seek medical services before proceeding. But again, people can go against that, but we want to talk about what is actually going on in the situation rather than ignoring it based on our own discomfort as well as our naivety. Naivety is not an excuse for not reacting in the most appropriate way. We're ethical social workers, so we need to stick to what we know. And as I said before, substance use, we need to assess someone for using any drugs or consuming any alcohol. This will be an idea of what their use looks like and explore the potential dangers or drawbacks of any of their use. So if you see any consideration in a question that someone has a history of substance use, current substance use, or any signs or symptoms of substance use, then you want to address that at the given moment. Why? That's safety. As I said before, if someone's withdrawing, they could die. If someone had drove to the agency intoxicated, that put everyone else around them at risk, and we wouldn't let them be able to leave. Why? Because that's a legal concern as well. But another one that we just talked about, if they're utilizing substances around children, then that's another book that just opened, and we have to read those chapters. Why? Because kids need to be protected in some way. So are they using around their children? If so, bad moves, bad vibes, need to report it. Is it the use putting them or someone else at danger? As I said, if someone's intoxicated on the way to the agency, or if they're supposed to be supervising people and they're utilizing substances, then they're not adequately able to supervise people that they should be. And we need to explore the impact that their use has on their functioning. Is their use being done responsibly, or is it being done irresponsibly, putting themselves at risk or other people's at risk, or in situations that they would otherwise not be in if they weren't utilizing the substances? So if you see any considerations of substance use in the question, it's a red flag, jump on it, and then figure out what the heck is going on and see if an answer matches that. And we also want to assess for intoxication. Is their use putting themselves or someone else at danger? Are they benefiting from the services at all? So if someone's intoxicated in the services, are they adequately able to communicate with you? And if they aren't, then what's the purpose of us having that session at that given time? As well as what is their motivation to change? So we're not going to push someone further than they want to be pushed. So if they're not motivated to discuss or address their substance use, then we can't entertain a dead horse. Why? Because it's dead and it's not being able to get back into it. But if they come to you and say, I'm motivated, I want to address this, I want to change my behavior, then we can talk and adequately broach that conversation. And I'm going to have a caveat here. I'm going to provide keywords, but do not word associate and see these words and jump to conclusions and say that's a safety concern. Because every time that you read an answer, you need to give it the respect and understand what is this question and answer in particular asking me, rather than seeing one word, assuming that this exam is black and white and getting punched in the face by the exam and getting it incorrect and then questioning your ability to answer questions. I will provide them as a way to get comfortable with the concepts, but do not word associate because it can lead to bad results. So if you see develop a safety plan, inquiring more information about a situation or speaking to X, maybe a person being abused or someone we think is being abused, explore current situation, CPS, depending on what's going on in the situation, but don't always assume where it says contact CPS or reach out to CPS that it's safety, because again, we don't word associate, we don't assume. We are ninjas of focusing and slicing and dicing the question before answering. So the next level of the acronym is feelings. So it's the client's subjective, and I'm going to emphasize on subjective. Why? Because it is subject to change based on the person's experience in some way, shape, or form. So a good example of this is, let's say you were super duper nervous about the process of how to get into this study group, or during the study group as I'm communicating, you're like, oh crap, I did not consider that. Maybe that's why I missed this question, or wow, hopefully I don't interact and see a question like this because it'll throw me off. But as we have been going on and I've been explaining it, or maybe as you get more exposure to the situation, your view and feelings about the situation is likely going to change the more comfortable and as the process goes on. So it's your subjective view, because it's subject to change, point of view of a situation and what is currently going on within that person's life, or what their perspective of what is going on is. It does not mean that it's absolutely true, but we want to recognize people where they're at and start with and for what they want to accomplish, what needs to get done, and what they want to see. So it's the client or patient's point of view that is subject to change based on their situation or information that they achieve, receive, or discover. So it's the client's direct feelings, their perspective of the situation, or simply information that can be a starting point for treatment. So if somebody walks in and says that they want to develop better relationships, and then there's all these other considerations after it, is that really what they want to go on? Perhaps, but maybe not. So always walking through the question and not just understanding what they say they want, but recognizing and understanding more. So if it answer is saying asking for clarification based on what the question has said, that could be a feelings option. But again, we don't word associate and we can't assume anything as it is. So the social worker needs to recognize where the client is and where they would like to go, not where we want them to go, where they actually want to go, and what the question says that they want to do and where they want to arrive. So we want to engage where the client is to begin developing a therapeutic relationship or rapport with the client. So if an answer is saying developing a relationship, developing rapport, etc., that's likely going to be a feelings one. But again, we don't want to jump to a conclusion. So it's the cliche. We need to start where the client is. So be aware of who the client is. Questions can throw multiple people into the mix, and we have to be able to decipher who actually is the client in the situation. If we don't, it's going to lead us astray off the path and fall into a hole. And I will say it again, I'll provide keywords, but do not word associate or utilize these as end all be all laws. So if you see validate, if you see recognize, if you see inquire, gather, elicit, etc., it should have a siren go off in your head that it possibly could be feelings, but read the entire answer and understand what in the heck in particular is it saying to you. So now moving on to the third level, assess. So this is the clinical or objective, and key emphasis on object, because it's an object and objects around you are hard to change. So you may have a cell phone next to you, you may have a water bottle next to you, you may have a TV next to you. So if you tried changing that object in front of you, it would take a lot of effort. In order for me to change my phone, I would have to snap it in half. Why? It's objective and it's an object. So objective information is difficult to change. So objective information is the bare facts of what is going on. So it's our clinical or objective information about a client situation and what their presenting needs are. It can provide us more information on the client situation beyond what they have already told us. So feelings is what they want to figure out. The assess or the objective information is what the heck is actually going on in this situation, what is realistic, and what is the information that can help us get closer and discover what's going on in the client's situation to better empower us as well as them to help them. So this information can be difficult to change since it involves direct observation and evidence for what has been and what is right now. So as I said before, we're not going to assume, we're not going to jump to conclusions, we're not going to add things, but we may utilize screening tools. Then we may contact family members. If we have a release, we still have to stay within inside of our ethical responsibilities. We may explore the client's history. What's their mental health treatment look like? What is their mental health symptoms? What medications have they tried? Are they on medications? Who is supportive in their life? What supports exist? What is their physical health, etc. All of those integrated biopsychosocial assessment questions that if you do intakes, you've seen a bajillion times are always relevant. Why? It's going to paint the absolute picture of what the client has been through and what they actually have within their life to help them accomplish their goals. We need to observe what the client's previous behaviors are and able to rechange what their current situation is to have a better future. So the starting point of the social worker and client working together to develop a plan of action to address the client's needs, wants, etc. So it's the glue that holds us all together. So the feelings is what the person wants to get out of it. Assess plus the feelings is what we are actually going to be able to do with and for the client's situation. So when we walk into the next level, this is going to be the only optional level of the entire acronym. And I'll emphasize that it is optional, but when it is relevant, it is cement. And what I mean by that is you're not always going to refer somebody out. There are particular reasons why you need to refer somebody out, but if it's relevant, then it supersedes the later levels of the acronym because the acronym is hierarchical. We start from the top and work our way towards the bottom. So the refer is us being able to provide different resources from other professionals or finding professionals outside of our agency to directly influence the client situation and elicit change that they are looking for to get out of services. And like I said, there are particular caveats here. This may involve us connecting them to the client to community resources, services that can help supplement the treatment in some way. Referrals to other professionals are based on the social worker not having the appropriate situation or experience to help the client. That is the biggest reason why we would refer out. We're not going to buckle down, use our clients as experimentation realms to gain experience. If we don't have the experience, then we're going to refer them out. If we have a little bit of experience or exposure to that topic area, then we can seek supervision to get the job done. But it is our responsibility to know when we can have the client and when we need to refer them out. So the social worker is exploring their limitations and finding ways to supplement them in some way, shape, or form. And as I said before, there are two possible options. You're referring them to somebody within your agency or referring them to somebody outside of your agency. So a referral to somebody within our agency would involve finding someone with the appropriate knowledge and expertise within a particular area of interest to better help the client with improving their identified issue or need. The other professional will have more experience than you do. So, for example, my expertise is substance use disorders. So when people have substance use disorders or co-occurring mental health and substance use disorders, at my agency, most people refer them to me or somebody else that utilizes and helps people in substance use disorders. Why? Because we have more experience than they do. or they can case consult. But at the end of the day, if somebody has more experience than you do, you tend to give them that because you don't want to hurt a client indirectly. So for example, the client needs substance use services and Phil does not have experience with treating clients with substance use disorders. However, Becker has experience with substance use treatment and could better treat the client. Therefore, Phil would refer the client to Becca for services. Why? She has more experience than Phil does, and he's not going to unethically practice. So we need to inform the client and make an informed referral. And the key emphasis is that the client has to be aware of this, and the client has to be okay with the change in clinicians. You cannot just refer somebody based on the sole fact that you feel like it's a good idea and it's convenient for you. Because if it's not convenient for your client as well, bad moves, bad vibes, unethical. We need to stay in our lane, inform the client, make sure they're okay with it, and then ship them away from there. And then the second option, referring to a professional outside of our agency, would occur when no one at our agency is about to treat or serve the person in an appropriate manner. And that's the key detail, is you're going to start in-house. If you don't have experience or anyone in the particular area in your agency, then you need to get them the heck out of there. So we need to make sure, and the key emphasis is on us, that the professional is competent and the location is available and accessible to the client of interest. Because again, if it's convenient for us, doesn't mean it's convenient for the client. And we would not just refer them for the sole fact that we feel like it's a good idea. They need to be on the same page because it's their services and their treatment that is on the line. So for example, somebody needs trauma treatment. Phil does not have experience with treating trauma, and no one at his agency does either. Phil would need to find someone with trauma experience, make the referral to the person that can better help treat the trauma. So we need to inform the client of the necessity of the referral, and that's the difference. We need to tell them why we're referring them, which is similar to the previous one, and ensure the referral is made appropriately and that the client is on the same page and able and willing to be able to make that exchange in some way, shape, or form. And there are other situations why you would need to refer out. We need to refer them when a client brings in something into the services or treatment that we can't seek supervision to improve. And they may be as follows. Social workers having a client that is sexually attracted to them. Why? Because you can't have a client and not be attracted to you. It's not their job. So we need to refer them out because we can't go seek supervision and say, hey, this client's attracted to me. How do I make myself unattractive to them? Or how do we change their mindset around this? So when the client brings something into the services that we can't change, then we need to refer them out for the sole fact that it's something that it is on their end. The client knows the social worker outside of the agency, but is a conflict of interest or dual relationship. We're not going to see somebody that is someone that we indirectly know or know personally. Why? Bad moves, bad vibes. Social workers connect to the client in another way outside of the agency. As I said, let's say you go to the same church as that person. Let's say you go to the same book club. Let's say you attend the same doctor or something, someone that's directly connected to you or indirectly in some way, shape, or form. We are not going to see that person because it's too close to home and they know mutual people. And the caveat here is, of course, rural communities, and because there may not be that many treatment providers, but it's up to us. We bear the burden to set the boundaries in some way so the client is aware of what is okay and what is not okay. And another reason why you would refer out is that the social worker knows of a community resource that could benefit the client, such as a support group, food banks, housing resources. And in this situation, the client will still be in treatment with the social worker. And it's going to get kind of tricky because another part of the acronym involves you sending them to another professional. In that case, they would also be still getting services from us, but it's in a different way because it's still at the same agency. And the keywords again, do not word associate, but utilize them as a guide. If you see refer, connect, coordinate, link, deliver, it may have a flashing light in your head say, this may be a refer category, but still respect the question and the answer choices and understand what they mean and how they can be applicable to your situation before just word association and assuming it's a refer and shipping them out like a bag of goods. And then educate is providing information about resources or services that we are about to provide, another professional will provide, or any areas of interest to the client in some way. So the goal of this level is to ensure that the client is aware of what to expect and so they can provide informed consent within their treatment. If a client's not aware and they don't have informed consent, then you cannot provide treatment to them in some way. And have to have the ability and capability of understanding what you're doing and why you're doing the things that you're doing. So the client is able to know what to expect and what is actually possible in their situation. And it allows for the client to have knowledge and competence around their own services or treatment. Or, as I said, particular topic areas that they're interested in. So, December 1, marijuana was recreationally legalized in the state of Michigan. That's where I live. So a lot of clients would come in and say, Phil, how could marijuana impact my services, or what is the impact of marijuana on my medications, or what is the different strains of marijuana, etc. And I had to be able and willing to provide that information to educate them so that they can make an informed decision on what would be the consequences or benefits in their situation in particular. But ultimately, it's up to the clients what they want to do. But at the end of the day, we need to allow for the client to be able to adequately know what to expect while in treatment, outside of treatment, or to better inform them on their ability to make sound decisions within their situation or for themselves. It is also for them to become more aware of particular topic areas. And as I said, marijuana use, their medications sometimes. In the question, you'll say client is unaware of side effects of medications, or they want to improve their relationship building skills, communication skills, etc. And we have to be able to provide that information and adequately assist them in some way. The next level of the acronym is 1/3 of the most trickiest parts of the acronym. People say the last 3 levels of the acronym are super duper confusing, and they are, because they are all the same thing. It's just a matter of who is delivering the services to and for the client. So advocate, emphasis on the A in advocate. A equals all by themselves. So this is where the social worker gathers the needed information, resources, and services, and the client delivers it to themselves. This is you providing them like an anger management sheet that they're going to utilize at home, maybe a token system, maybe it's communication skills, but you're providing it and they're utilizing it outside of the agency. And right now, you may be saying, what's the difference between advocate and educate? Educate, they're utilizing the information and obtaining it in the session. Advocate, we're giving them the information and they're applying and utilizing it outside of the agency in some way. So at this time, we're allowing for the person to determine whether they utilize their benefit from a particular part of treatment. So if you do direct practice, I'm assuming that you have gathered the sweetest information or resource sheet in the world. You give it to the client and then they leave. They come back for their next session. You ask them if they utilized it and they say no. That is this level, because it's not up to us to follow up and force them to do something. Advocate is where, if you picture an advocacy rally, we are advocating for a particular interest or topic area, but it's up to the people that obtain the right and resources to utilize it in some way. So it allows for the person to have control and to reinforce their work while in treatment. So it kind of puts the ball in their court rather than us pushing and driving and telling them what the heck to do. And as I said, it's kind of gathering together for a cause, but it's up to the person to exercise their right. So the client will be the main factor in their progression or regression in services in some way. And a couple of examples to articulate this level of the acronym are as follows. Phil has problems with time management and would like to be able to improve it. A social worker provides him a planner that he can utilize while at home. And the key emphasis, he can utilize at home. I'm not sitting in session. The social worker and I are not developing a schedule. It's up to me to utilize this planner at home. So it's up to me to fill it out and utilize it to improve my time management skills. But if it was someone following up with me, if it was someone directly doing it for me, then we're looking at another level. Another example, Phil is doing a study group on the acronym and walking through practice questions with social workers who are preparing to pass their ASWB exam. Phil provides them the information for the acronym and leaves it up to the participants to utilize it or not. So the participants have the information regarding the acronym. It is up to them to whether they benefit or utilize it in some way, shape, or form. So it is up to the people to get the job done, but at the end of the day, Phil just provides the information. Another example, Rebecca's been struggling with balancing studying for the social work licensure exam and handling her anxiety while answering practice questions. So Phil provides Rebecca information on how to break down the questions, combat her anxiety, and to remain focused while preparing. It is up to her whether she uses the information or not. The next level of the acronym is facilitate. So, as I said, advocate, facilitate, and intervene are all the same thing, but it's a matter of who delivers the services. An emphasis on F for facilitate, because F equals friend, because a friend of ours is going to work with and help the client in some way, shape, or form. So it's when the social worker gathers the needed information, resources, and services for the client, and another professional delivers the service to and for the client. So someone is influencing the likelihood that someone will benefit from the services and or that the client's needs are being met in some way. So it's the act of someone assisting a client with getting their intended result or results from services, and the professional serves as a sense of accountability. So someone helps connect you with someone to get further along in the process. So if you think of facilitation, someone is empowering someone else to get the job done. So I am helping this person and then connecting them to an accountability person or another professional with expertise beyond mine to help them, but they are still in services with and for me, and refer or shipping them out unless it was a community resource, and then they're still with us. But in a couple of examples to bring it all home. So Phil gets a list of anger management techniques from his therapist to try at home, and Darlene is contacting him daily to inquire about the utilization of the techniques provided. And the key emphasis is that Darlene is serving as an accountability person and following up with Phil in some way. So someone is following up with Phil to ensure that he is getting his needs met or increasing the likelihood that he reaches his intended goal, which was to decrease his anger. Another example, Phil is working with a client who struggles with depression and who recently lost his housing. Phil connects the client with a housing specialist at his agency to ensure that his client gets his needs met. The client would still work with Phil, but they are getting additional assistance. So connects with a housing specialist at the agency, but they are still working with Phil. So he made that connection. So Phil has been working with the client and connected him with another professional to get his needs met. So another way to conceptualize this level, it's like having case management services. You will have a primary therapist, but the case manager is filling in and having more direct contact and facilitating that situation. Another example, Barb has been working to pass her ASWB exam and has not been successful. She has a friend, Jody, who has been watching this guy on YouTube. Barb reaches out to this guy on YouTube, who happens to have the first name of Phil, to increase the likelihood that she will pass her exam. So she tried doing it on her own. Jody connected her to another person to help impact her situation in some way. So the act of Phil following up and providing guidance to increase the likelihood is that facilitation. Jody provided the referral source or services in some way, and Barb followed up with it, and now she's getting additional assistance with the process. So the last level is intervene. Key emphasis on the I in intervene is I equals I do something in the situation. So when the social worker will gather information, resources, and services for the client, and they are the people providing the services with and for the client in some way. So this is the level everyone loves and jumps to on the exam. Why? We all have a superhero complex of wanting to help people, but slow it down. We start away from us and get closer and closer as the process goes on. So it's whenever the social worker does an action to elicit or promote change in some way to ensure that the client's needs or wants are being addressed. And the key emphasis is that we are doing an action or working with them to get the job done. So when the social worker helps to develop or deliver plans for or with the client, they will work with the client to ensure that they're getting closer to their goals. So for example, Phil wants to better handle his anger. So the social worker he's working with provides him a list of anger management techniques that they identified together. So they identified them together, and the social worker will follow up with Phil to ensure that he is improving his anger and utilizing the techniques that they went over. So the social worker worked with Phil to identify the strategies, and they are following up with him to ensure his anger is being addressed and improved in some way. Another example, Rebecca has been feeling more depressed since her brother moved away, and she meets with a therapist to discuss it. The therapist works with Rebecca to identify positive strategies to improve her depression, rather than providing her a list or connecting her to another professional. The social worker worked or assisted her themselves. The last example, Jack has been struggling with understanding how to break down questions and stay motivated to study for her ASWB exam. She reaches out to a guy named Phil for assistance. Phil connects her with and works with her on how to break down questions to remain motivated throughout the process. So Phil directly interacted with Jackie rather than just providing feedback or shipping her off to someone else or having another professional in some way. And he impacted her situation directly. So he is the one that initially made contact and received it and is like, let me help you out and let me get this process done. So anytime the social worker does an action, it is intervene. So quick review of the acronym in an easy, super duper way to remember it. The acronym starts with the client and moves towards the social worker as it progresses. So safety is focused on the well-being of the client, not about the social worker in any way, and the potential harm to them or for someone else. Feelings, it is all focused on the client's view and their needs. Again, it's not what we think they need to do, it's what they want to get done. Assess, it is focused on the client's history and their situation rather than the key details that we think. We're just gathering the information. Refer, it's focused on the client's needs and directing them in the best way to get their needs met. Educate is focused on increasing the client's competence and the knowledge of their own situation and treatment. Advocate is focused on allowing the client to take control of their situation. And as I said, A equals all by themselves. Facilitate, F is for friends because we're going to ship them to another professional or a friend that we know. It is focused on the client working through their struggles to make progression and connecting with another professional to help. And the last resort is it is focused on the social worker working with the client to get their needs met. So we are the last resort. And as I said, I equals I do something. And an easy way to recall the acronym during the exam, a savvy farmer Aladdin raises expensive apples from India. Savvy safety farmer feelings Aladdin assess, raises or refer, expensive educate, apples advocate, from facilitate, India intervene. And the acronym is only for application questions. Do not apply the acronym to all the questions because it's going to lead you to being confused and off the path of where you need to be. And you may be wondering, what the heck are the types of questions, Phil? Well, let me tell you guys. Recall, application, and reasoning. So recall are the questions that every single person wishes the exam was on and what the questions look like when we are in college. They're the one-worded answers and they want specific recall type information. So Freudian theory, medications, diagnosis, Kohlberg's. This is the content-based questions that everybody loves. This is what most prep programs will tell you the exam is about. Bad moves, bad vibes, because the majority of the exam is on application and reasoning. So application is where we need to apply the specific social work terms, theories, concepts, and ideologies to specific client situations. So they tend to be clinical write-ups and ask for the social worker to respond in an appropriate manner. Where recall questions were where we had to just simply identify specific social work terms, concepts, and theories. So application is where we have to apply what we know into a particular situation and peel back the layers. Which an example here is a client presents with depression symptoms, anxiety symptoms. They are homeless, utilizing substances, and have high blood pressure. Where should the social worker start? What should the social worker do first? What should the social worker do next? What is the most likely thing for the social worker to do, etc.? So in this consideration, we have somebody that has depression. We have people that have anxiety. This person is homeless. They are utilizing substances and they have high blood pressure. So in this particular situation, we'd rule out depression, anxiety, and their homelessness for now. So then we have two levels of the acronym: safety, substance use, and high blood pressure. And at this time, we would want to utilize this, assess the substance use, because it's the most imminent harm, because it does not say that they're not taking their high blood pressure medication. But that's how we'd have to peel back the questions, is that we had 5 different considerations and we have to highlight what is the most important at the given time in the situation. Which the types of questions, like I said, the one word that you'll see is first, next, best, most, and should. And then reasoning questions are where we need to come up with a specific solution to a problem. And these are typically our ethical dilemmas, where we have to address a problem with the client interactions, our research questions, community questions, etc. Anything where it can involve a client situation, but we have to look at our ethics. What is our program evaluation? What is our program development, etc. And they have the same first, next, best, most, and should specifiers. So do not let that one single word blow your mind and dictate how you answer. Due to contrary belief, one word is not going to change everything. So, as I say that, let's figure it out, because first, next, best, and most are all the same thing. They have the same meaning. They're getting at the same thing. So don't lose your mind when you see it. Sometimes people will say, Phil, well, it was a best question. If it was a most question, I would have answered it like this: bad moves, bad vibes. They all mean the same thing. So rock with me for a second and I will show you. Which should the social worker start with in the situation is when it is first. If it's a next question, it's what should the social worker start with when reacting to the situation that has already been described. So first is, what is the absolute first thing? Next is, what is the first thing after everything that has been described in the question? Best, what should the social worker do first when responding to the situation? And then most, what is the best explanation or appropriate action the social worker should take in this situation? And an example that I'll give is, let's say Phil was baking a cake. What should Phil do first when baking a cake? Well, put the mix in the bowl. Let's say Phil has all the ingredients on the counter, has the bowl on the counter. What should he do next? It'd be the same thing. Put the contents in the bowl. Let's say, similar situation, Phil has all the ingredients, has the bowl on the counter. What is the best thing for him to do in this situation to bake the cake? Put all the ingredients in the bowl. And then most, Phil has all the ingredients on the counter, has the bowl ready. What is the most likely thing for him to do in this situation when baking a cake? Put all the ingredients in the bowl. Ding, ding, ding. They are all the same thing. So at that moment, don't let one word blow your mind, because a lot of times people put energy and pressure on themselves based on that one word, and it throws them off the entire exam. or they've been told that different strategies are utilized for different specifiers on that. Bad moves, bad vibes. Stick with what you know, keep it simplistic, and let's utilize the contents of the question to answer the question rather than one word at the end of it. And then there's a 5-step consideration that I always tell people to utilize when breaking down the questions. So who are you? What type of social worker are you essentially? Are you in an outpatient? Are you in a hospital? Are you in a school? Because if you're in an outpatient setting, our job is to assess, stabilize, maintain, and then discharge them. It's a little more long-term than its counterpart of a hospital, which is assess, stabilize, and discharge them immediately. And then in a school, we need to assess, stabilize, monitor. They graduate into the next grade, assess, stabilize, monitor, all the way until they actually get their diploma or etc. And then the second consideration is, where are we at? What setting in particular are we looking at that can help paint this picture differently? So the two examples that I'll give: in an office, social workers are going to base all of their information on what the client tells them as they are being presented by the client. Why? We don't have any follow-up. We only get to know what the client tells us and what they want us to know. However, if we're in the community, we can base all of our information and work on what they tell us, as well as observe while meeting with the client what other considerations can be. What is their home environment? What's their financial situation? What is their supports? Is there any safety concerns, etc.? But in office work, you only base it off what the client is able to tell you. In the community, you're able to assess and address that more. So if you see these different elements within the question, utilize them to your benefit. If you don't see them in the questions, don't freak out. Just skip over the step and utilize the contents that are within your question. And then the most important considerations are 3, 4, and 5. Who is or who are your clients? As I said before, you may have multiple people in this situation, but only one person is of consideration. So who is providing the information and who is it about? The client will often be in the correct answer and allow for you to be able to connect the answer back to the question in some way, but maybe not all the time. But make sure the contents are relevant and the focus of your answer is on the focus of the question. So the question will often tell you or be focused on the client of interest. So if, for example, you're working with a family and all of the question is about a son, the client is no longer the family. The client is now the son. So the son has to be a part of the answer and vice versa. The fourth consideration is, what is being presented in the situation? What symptoms are we seeing? What situations, what considerations, etc. are being brought up and put in front of our face, so that way we don't prioritize the wrong thing. Questions will have a lot of considerations, but if you overlook the key details, it's going to lead you to getting the wrong answer. So we will often be shown multiple factors in the question, and we'll be able to and need to know how to prioritize them in order to become competent and relevant in getting the correct answer. The fifth and final consideration is, what we can or what does the question want us to do about the situation or the symptoms or the X amount of criteria that are being described in front of us. So essentially, how do we react to the symptoms and situation that the client is being presented with? And oftentimes, the last sentence of the question will help guide the answer. However, stick to your gut, trust yourself, and if you have thoughts on a different answer than the last question is asking you, then go with it. Why? Because we can't word associate and have this exam structured black and white. It's in the gray, and some considerations as well as client work is not that directly open like that. And then 7 additional tips: read the question 3 to 4 times. And before you say, Phil, I'm going to run out of time, they have purposeful and meaningful reads. And the more time you practice this, the easier it will be to get the correct answer or get to the answer faster. So the first time you read the question is just simply to understand the situation. The second time is to break down the question and the situation and pull out the key details. And the third and fourth time are to compare your answers back to the question to make sure they align and connect, because if your answer doesn't connect back to the question, you're probably not answering the question that they want you to. The second consideration: never, ever, ever, ever second guess yourself. This will cause your anxiety to skyrocket, which can destroy your confidence throughout the rest of the exam. Because let's say you're on question 5, you second guess yourself, you're not sure. You move to question 6, it may be all right. You move to question 7, and you're still thinking about question 5 because you second guess yourself, which could cause you to second guess yourself throughout the rest of the exam because you don't trust yourself to actually be able to pass this stinking thing. The third consideration or tip is to trust yourself and base your answers and preps on what works best for you and not for what worked best for someone else or what someone else told you would work best for you or how they pass the exam, because you know your learning style, you know what's worked for you, and you prepared in the best way that you know how. And don't let the impacts and influences of someone else dictate and influence how you answer and navigate your process. The fourth one is develop a routine because it'll allow for you to know what to expect and keep your anxiety in check, because with clarification comes comfortability. So you'll have to plan out what you'll do the day before, what you're going to do the day of, what you're going to do when you become anxious during the exam, and what is your answering process and question reading and breaking it down. As I said, I've provided a decent amount of suggestions, but stick with what you know rather than what I'm telling you to do, because you know yourself best. But trust yourself and never stray away from what you know and what you feel is necessary of passing this exam. The fifth is to invest in yourself and allow for yourself to have leeway when preparing. Do not expect perfection when preparing or taking the exam. We are human and we'll make mistakes and get things wrong. And you're allowed to get 45 to 54 questions wrong on the exam, depending on the version you get. So don't let one question throw you off the path and dictate how you're going to view yourself as well as your result. Because you may sit down in that exam, the first question may punch you in the face, but you have to be willing to keep going, keep stepping into the fire, and keep doing the things that you know is necessary to get the job done, because one question is not going to dictate everything. So you have to keep rolling and keep going and keep rolling and keep going, keep rolling, keep going, keep on the path, because with persistence comes results. We're not looking for perfection here. We're looking for permanency as well as progression. And the sixth, do not let the little things distract you or destroy the big picture. Meaning, don't let the little things in the question throw you into a rabbit hole and then you can't get out and then you're not focused the rest of the exam. Don't let one question, one wrong answer, one etc. get in your way of the big picture. This exam is 170 questions, so don't let one question throw you away from the whole 169 other ones that are in front of you. Or if you're preparing still and doing practice questions, key emphasis on practice questions. They're utilized to be having practice and getting further exposure and exercise. And if your routine's working for you, don't let that wrong answer or one question ruin your entire thing or your mood or make you question your ability to be able to take this exam and pass it in general. And seventh, identify a way to rest your mind when finding it wandering or into anxiety in some way, because if you don't know what to expect, you'll never know what the result is. So you know what works best for you. So bring that in, create that, know your trigger points, know things that could stray you away, know the effective ways to get yourself back on track. Because if you find yourself getting off a track, then you're not going to get to the right end result or the finish line like you want to. So remember these things, keep them with you, and let's get down to business. All right, question 1. A social worker in a private practice is meeting with a husband and wife to help improve their relationship. The woman reports that her husband does not listen to her and spends a lot of time reading about numbers. The man reports he is trying to crack the code to the stock market to make them rich. What should the social worker do first in this situation? A, explore how the couple would like to improve their relationship. B, provide information on effective communication to the couple to help guide the treatment. C, gather information regarding the husband's mental status. D, collaborate with the couple to identify ways to improve their relationship. And when you have your answer, type the word happy into the chat. Opening the polls. 30 more seconds. Slapping the polls shut. The majority think it is A. Second place is D. Third place is C. Fourth place is B. Let's look at it. So we have a social worker in a private practice. We are meeting with a husband and wife. So they are possibly both our clients and they want to improve their relationships. So the woman reports her husband does not listen to her and he spends a lot of time reading about numbers. The man reports he is just trying to crack the code to the stock market to make them rich. What should the social worker do first in this situation? This is an application question, why it's a client interaction. We have to intercede and apply our social work knowledge to help answer the question in some way. So let's utilize the acronym to break it down. Explore how the couple would like to improve their relationship, feelings, why we're gathering their perspective on what they want to do in this situation to help them in some way, shape, or form. Provide information on effective communication to help guide their treatment, educate why we're providing them information on effective communication to impact their services, gather information regarding the husband's mental status, safety. Why? Because mental status and psychosis is a part of the safety process, and we need to make sure he's not psychotic in some way, shape, or form before proceeding. Collaborate with the couple to identify ways to improve their relationship, intervene. Why? Because we're working with them and for them in some way to help them. So, quick review: private practice, husband and wife, they want to improve their relationship. The woman reports her husband does not listen to her, spends a lot of time reading the numbers. The man reports he's just trying to crack the code of the stock market to make them rich. What should we do to help them in some way? We would rule out D because that's an intervene, and we're not immediately going to hop in and have our Superman or Superwoman cape on and say, I need to work with you guys and identify ways to improve your relationship, even though I don't even know what you guys want to improve. Bad moves, bad vibes. And we're also going to rule out provide information on effective communication to the couple to help guide the treatment. Why? Because we don't know that they want to communicate better. We don't know that that's their goal. We're not sure what the heck's going on in their situation. So we need to ask rather than assuming. So we can either explore how the couple would like to improve their relationship, or C, gather information regarding the husband's mental status because he's super fixated on numbers and thinks that he's going to crack the code to the stock market in some way. So at this given time, we're going to rule out A because, yes, we want to explore what they want to get out of it, but the wife is the only one that's invested. Husband doesn't seem that he's interested in services in any way, shape, or form. And the comments that he's making, and if you guys know psychosis, most preoccupations are on numbers and religion. And he believes that he's going to crack the code of the stock market and is super fixated on numbers. So we want to gather information regarding the husband's mental status to make sure that he's not psychotic or posing danger to himself or others in any way, shape, or form. And it's a safety issue because, as I said, psychosis and mental status falls under that, because if someone is not in oriented times 4, or if they're exhibiting delusions, hallucinations, or anything like that, it could be danger to someone else as well as themselves. Tricky question, but sit back and we will see what happens in the future. Question 2. A school social worker has referred a 6-year-old girl for concerns with inappropriate sexual gestures. The teacher reports that for the past 3 weeks, the girl has been putting her hands in her pants throughout class. The teacher reports that recently during recess, the girl was caught masturbating and is not sure what to do. What should the social worker do first in this situation? A, contact Child Protective Services. B, ask the girl why she is doing the behavior and where she learned it. C, provide information regarding normal sexual development to the teacher. D, Contact the girl's parents to understand where the girl may have learned the behavior. And when you have your answer, type the word water into the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is B. Second place is A. Third place is C. Fourth place is D. Let's look at it. So we are school, social worker, our client, 6-year-old girl, concerns for inappropriate gestures. Teacher reports for the past 3 weeks she's been putting her hands in her pants throughout class any length of time. Jump on it because it paints the picture and lets us know what is going on. So this has been happening for 3 weeks. The teacher reports that recently during recess, the girl was caught masturbating and is not sure what to do. What should the social worker do first in this situation? Well, if you haven't guessed it, it's an application question. Why? It's a clinical scenario and we have to respond to it in some way, shape, or form in the best way that we know how. So let's apply the acronym here and see how it does. So contact Child Protective Services. We have safety or intervene. So as I said, CPS could be safety if there's actual safety concerns, or intervene. Why? Because it's an action on our part. So it can be both depending on what we are doing in the situation and how we're going to view it. Ask the girl why she's doing the behavior and where she learned it. That one is going to be feelings. Why? Because it's getting her direct perspective of what's going on in the current situation. Provide information regarding normal sexual development to the teacher. Educate. Why? Because we're providing information to better inform the decision-making process. Contact the girl's parents to understand where the girl may have learned the behavior. And that one's going to be intervene. Why? Because it's us doing an action to further develop the situation. So quick review, school social worker, 6-year-old girl, concerns with inappropriate gestures. The teacher reports for the past 3 weeks, the girl has been putting her hands in their pants. The teacher reports that recently during recess, the girl was caught masturbating and is not sure what to do. So at this given time, we're immediately going to rule out contacting the girl's parents. Why? Because they're not going to be able to tell us where she learned this behavior because they may not know. Also, it could be assumed that it's accusatory and you're contacting a family and saying, where in the heck did you learn this behavior from? What'd you teach her? What are you molesting? Bad moves, bad vibes. So then we can contact CPS, ask the girl directly, or provide information regarding normal sexual development to the teacher. So at this time, we're going to rule out CPS. Why? Because this girl's has no signs of that she's actually being abused, because most people that are being abused are doing the behavior to other people, acting it out on toys, having more reactionary things. So at this time, we're going to make contact CPS intervene. So we're going to rule that out. So at this time, we have to consider, are we going to have a 6-year-old girl tell us why she's masturbating and where she learned the behavior? Or are we going to say, hey, this is human developmental theory, maybe actually normal behavior, because she's not actually utilizing the techniques on other people and may not even know where this is coming from. So at this time, we have a 6-year-old girl, and if we know our human developmental theory, we know Freudian psychosexual theory. 6 years old is about the phallic stage. Phallics, where they're actually experimenting with their genitals and understanding that they have it. So at this time, the acronym is going to deceive us, and it does not always apply all the time. That's why I said be careful, understand what the questions and answers are telling us, because we are going to rule out B, because we're not going to have a 6-year-old girl tell us, why are you doing this behavior? Where did you learn it? And we are going to use our human developmental caps and say, I'm going to provide information to the teacher and say this is sexually appropriate or developmentally appropriate at this given time. And there's no inclinations of abuse, because most people that are doing abuse are doing the behavior to other people and are acting out sexual acts in some way. So that's how we look at that question in particular. Be careful, compare your questions and answers back to one another, make sure they connect, and don't rely on the acronym 100% to get you there, and figure out the answer and make sure they connect. So let's get down to business. A social worker in an outpatient clinic is meeting with a 33-year-old mother who recently left an abusive boyfriend. The mother reports that her ex-boyfriend was physically and emotionally abusive towards her and her children. The woman reports having guilt around the fact that her children had to experience what they did. The woman would like to obtain information on ways to improve her situation. What would be the best thing for the social worker to do in this situation? A, contact Child Protective Services. B, provide the woman information on how to begin coping with past trauma. C, validate the woman's strengths to leave her the relationship and seek out assistance from the social worker. D, gather information regarding the abusive relationship and the impact it had on the woman. And when you have your answer, type the word practice in the chat. Opening the polls. Thirty more seconds. Slapping the poll shut. The majority think it is C. Second place is D. Third place is A. Fourth place is B. Let's look at it. So we have a social worker outpatient clinic meeting with a 33-year-old mother. She recently left an abusive boyfriend, so she's out of the situation. The mother reports that her ex-boyfriend was physically and emotionally abusive towards her and her children. And the woman reports having guilt around the fact that her children had to experience what they did. So the woman would like to obtain information on ways to improve her situation. At this time, application question. Why? Because it's a clinical scenario. We have to respond to it in some way. So let's apply the acronym, shall we? Contact Child Protective Services. We're looking at safety and intervene, depending on how we want to look at the question. So we'll peel it back a little later on. Provide the woman information on how she can begin coping with past trauma. Educate why we're providing her information to better equip her and have her provide informed consent. Validate the woman's strength to leave the relationship and seek out assistance from the social worker. In this particular situation, we're looking at feelings, why we're recognizing where she is and commending her for doing something that is very, very difficult for her. Gather information regarding the abusive relationship and the impact it had on the woman. At this time, it's going to be assessed. Why? Because it's going to be gathering information and clinical information on that could help progress us in some way, shape, or form. So, quick review. Outpatient clinic, 33-year-old mother. She has left the abusive relationship. So, that is a key detail in the question. She recently left it. Her ex-boyfriend was physically and emotionally abusive towards her and her children. She feels guilt around it, and she would like to obtain information on ways to improve her situation. So, at this time, we're going to rule out safety concerns. Why? Because she's no longer in the relationship. Kids are safe now that we know of, and they're outside of it. So we're going to rule out contacting CPS because we're not going to make a report on something that is already done and she's out of the situation and improving their situation in some way, shape, or form. So that's why that one would get ruled out. We're going to rule out providing her information on how to begin coping with the past trauma. Why? Because we don't even know that's what she wants to work on. At this given time, she's throwing multiple layers at us, and we aren't sure what this lady wants to work on in some way, shape, or form. So at this time, we can either validate the woman's strengths to leave the relationship and to seek services from the social worker, or gather information regarding the abusive relationship and the impact it had on her. So at this time, we're going to rule out D because, as I said before, she may not even want to explore the abusive relationship. She may just say, yep, that's behind me. Bad news, bad vibes. I'm moving on. And at this time, we want to commend her and validate her for leaving an abusive relationship, because reflect on how many people actually leave the abusive relationship that she's in at the time, and that she's seeking out assistance, how difficult it must be to leave an abusive relationship and then also work with us at this time and trust us enough, even though she just got out of a relationship that had her do the contrary. So at this time, we're going to recognize her feelings. We're going to recognize the strength it took to get into our office and walk on with this journey with this woman in some way. So that's how we look at that question in particular. Question 4. A social worker at a family agency is working with a mother and her 7-year-old son. The mother reports that her son does not listen to her and will have behavioral issues when he does not get his way. The boy reports he does not see anything wrong with his behavior, as his mother does anything he asks her to do. The mother reports her son was recently suspended from school for pushing other children. What parenting style best explains the mother's behavior? A, uninvolved. B, authoritarian. C, authoritative. D, permissive. And when you have your answer, type the word tricky in the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is D. Second place is B. Third place is A. Fourth place is C. Let's look at it. So we have a social worker, family agency. We're working with a mother and a 7-year-old son. The mother is saying that her son does not listen to her and will have behavioral issues when he does not get his way. The boy reports he does not see anything wrong with it since she does everything that he asks her to do. And the mother reports he was recently suspended from school for pushing other children. So this question is going to be a recall question. Why we have to know the specific social work terms, concepts, and theories to be able to address and assess this question. So we have to know the parenting styles. So uninvolved is when the parent is absent from the child and the child is left to take care of themselves. Authoritarian, when a parent takes control and does not allow their child to have any say in their life. Think of a dictator. And then authoritative, when a parent and child will work together to develop a situation that works best for both of them. Child is provided choices and not controlled. Permissive, the child runs the roost and the parent does whatever the child wants. So the parent is more of a friend. So quick review. Family agency, mother and 7-year-old son. Mother reports her son does not listen to her. He'll have behavioral issues when he doesn't get his way. The boy reports he does not see anything wrong with it because his mother does whatever he wants him to. He was recently kicked out of school for pushing people. So at this given time, we're going to rip out authoritarian because if anything, the boy's being authoritarian towards his mother and telling her what she needs to be doing for and with him to get his needs met. Authoritative would be ruled out because yes, the kid's having some say in a situation, but the mom is not holding him accountable at all and isn't really parenting him at all and is just doing whatever the heck he wants just so he won't have behavioral issues in some way, shape, or form. Uninvolved would be if mom was like, all right, I'm going to the neighbor's house, cook dinner for us, I'll be back. So she's not uninvolved in the situation because she's actually involved in the situation. She's just coddling and doing whatever the heck he wants her to. So why would he want it to change? At this given time, it'd be permissive because she is being permitted to do whatever the heck he wants and is dismissive of her own needs and accountability for the child based on the fact that she doesn't want him to have behavioral issues. So that's how we look at that question in particular. Question 5. Social worker in an outpatient clinic is completing an intake assessment with a 24-year-old female who presents with concerns of excessive gambling. The social worker explores the severity of the woman's gambling and triggers for it. The woman reports that whenever she gets into arguments with her aunt, who she stays with, that she will gamble to help pay for her part of the rent. The social worker has been dating someone for the past 4 months with a niece that has a gambling issue and believes the woman she was referring to is her client. What should the social worker do in this situation? A, attempt to gather information from the woman to ensure the aunt is the woman he has been dating. B, continue with the intake, but before refer her to a different therapist when you complete. C, refer the woman to a different therapist to avoid any chance of a dual relationship. D, continue with the intake but seek supervision around the potential dual relationship. And when you have your answer, type error into the chat. Opening the polls. Thirty more seconds. Flapping the poll shut. The majority think it is C. Second place is D. Third place is A. Fourth place is B. Let's look at it. So we're in an outpatient clinic, completing an intake assessment with a 24-year-old female, presents with concerns of excessive gambling. Social worker explores the severity of it and identifies triggers, so we're examining what's going on. The woman reports whenever she gets into arguments with her aunt that she stays with, she's going to gamble. She wants to pay for her part of the rent, so the arguments are probably predicated based on the fact that money issues. Social worker has been dating someone for the past 4 months with a niece that has a gambling issue, and he believes that the woman he is dating is related to the client. What does the social worker do in this situation? So at this time, we're looking at a reasoning question, why it's an ethical dilemma, and we have to refer to our code of ethics, how we need to be an ethical social worker and exercise our right to get the job done. So at this time, we're going to rule out A because we're not going to fish our client to figure out details about the aunt. The aunt's not the client, and it's not the client's issue based on the fact that we were possibly dating somebody that she knows. So we're not going to fish for some details, bad moves, bad vibes, just because we want to know and we need to figure out what's going on, does not mean that we are going to be asking the client directly about the ant. It's creepy, kind of weird, and the client's probably going to be perturbed and wonder why you're asking about the ant. So at this given time, we're going to rule out C, because C is saying, all right, stop it. We're stopping the intake right now, and I have to get you to another clinician before we can proceed. Bad moves, bad vibes. Yes, we want to avoid any chance of a dual relationship, but we're not going to stop mid-intake and say, yup, I cannot continue with this intake with you right now. And then the client's like, well, why? I can't tell you. Just go to another clinician. Because we're not going to tell the client, hey, I'm probably dating your aunt, because that's bad moves and bad vibes. Because at this time, we're not stopping the intake. So we can either do two of the answers that are super duper similar, which is continue with the intake and continue with the intake, because we're not completed with it. We are completing, meaning it is still in progress, baby. We have not completed the process, and we need to walk it all the way through and get the job done. So we can either continue with the intake, but refer her to a different therapist when we're completed, or we are going to be seeking supervision on what to do in regards to the potential dual relationship. And at this time, we're going to rule out D, because if there's a potential dual relationship, we need to get out of here. We don't want to run that risk of we continue seeing the client, schedule appointments with her, seek supervision, and then we're at the same dinner table. So now we're dating the aunt, and we have a client that is under the same roofs. We need to make sure what we're doing is what we need to be doing. Those that wanted to refer her out, we're on the right track, but we're not stopping the intake mid-stroke. So the correct answer here, refer them out prior to the dual relationship forming, because if there is a dual relationship, we bear the full burden of that dual relationship in the given moment of setting boundaries in some way. But if we end the relationship, we can still have a relationship with the aunt. So that's how we look at that question in particular. Question 6. A community-based social worker has been trying to reduce the rate of drug-related overdoses in our community. The social worker implemented a self-referral based intervention to the members of her community, but recently had to shut down the program due to the lack of engagement. The social worker reached out to key stakeholders in the community, and they agreed on the already established goals for the program. What should the social worker do next in this situation? A, reassign the roles of the members on the task force to increase engagement. B, reevaluate the goals and change them to what will best help the community. C, change the layout of the program to ensure that it increases the amount of engagement. D, relaunch the current format of the program to help save resources in the long run. And when you have your answer, type the word community in the chat. Opening the polls. 30 more seconds. Slapping the polls shut. The majority think it is C. Second place is B. Third place is A. Fourth place is D. Let's look at it. Community-based social worker, trying to reduce the rate of overdose-related in our community. Social worker implemented a self-referral based interventions to the members of the community. Recently had to shut it down because engagement was not there. Social worker reached out to key stakeholders in the community, meaning people that represent people that we're serving. They agreed on the already established program goals for the program, meaning the goals that we had prior that we all worked together. They agreed on and said, double down. We think those are good. So at this time, this question is going to be a reasoning question. Why? Because it's looking at community and program development, and we have to come up to a solution to a problem of something that's not currently working. So quick review, community-based social worker, we're trying to reduce the rate of drug-related overdoses. We implemented a self-referral-based intervention. We had to shut it down. No one was engaging, and key stakeholders are saying double down. The goals that we established prior with the community members is what we want to keep doing. At this time, we're not going to reevaluate the goals and change them to what will work best to help the community. Why? Because the people in the community said these are the goals we want to work on, and we want to keep doing that because they were already established and they were like, yep, we want to keep those going. So they were already established goals. So we're not going to reinvent the wheel because we need to serve the community and not tell the community what they need to get out of the services that we're providing. At this time, we're also going to not relaunch the current format of the program to help save resources in the long run because resources are not our focus. It is the clients that we're going to be serving and the results. Yes, we can relaunch the current format, but it hasn't worked. So we need to reconsider how we're going to deliver it or what we're doing in this particular situation to deliver it. So we can reassign the roles of the members on the task force to increase engagement, or we can change the layout of the program to ensure that it increases the amount of engagement. So at this time, we're going to rule out reassigning the roles of the members on the task force because there's no telling that the task force can readjust itself to engage more. So the easiest and probably the most effective is saying what in the program is not working at this time and how can we increase the engagement of that program? Because we were using a self-referral based intervention, maybe snowball sampling, us actually going to the community and seeking people out. So the way that we're delivering the program is likely the problem rather than the people that are delivering it. So at this time, we're going to change the layout of the program to ensure it increases the amount of engagement. So that's how we look at that question in particular. Question 7. A social worker is meeting with a boy and her 14-year-old son who is deaf. The boy's mother serves as an interpreter throughout the session. The boy reports that he has been finding it difficult to fit in with people at school and that he has been bullied. The boy reports that he has fleeting thoughts of suicide and previous suicide attempts. The boy would like to identify ways to improve his mood and decrease the frequency of his suicidal thoughts. What should the social worker do first to help the boy? A, develop a safety plan with the boy to ensure he has ways to combat his suicidal ideations. B, provide the boy information around interpretation services to improve the quality of his services. C, gather information around what the boy's suicidal thoughts look like. D, inform the boy about a teen group at the agency that could help him develop positive relationships. And when you have your answer, type one thing that you're excited for next week. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is A. Second place is C. Third place is B. No one thought D. Let's look at it. Social worker meeting with the mother and her 14-year-old son. The son is deaf. The boy's mother is serving as an interpreter throughout the entire session. The boy reports that he is finding it difficult to fit in with people at school and that he's been bullied. The boy reports he has fleeting thoughts of suicide and previous suicide attempt. The boy would like to identify ways to improve his mood and decrease the frequency of his suicidal thoughts. At this given time, we're looking at an application and a reasoning question. Why? Because we have a clinical consideration that we have to respond to, but there are ethical considerations in the background. So, develop a safety plan with the boy to ensure he has ways to combat his suicidal ideations. That would be safety. Provide the boy information around interpretation services to improve the quality of his services. Educate why we're providing information in some way, shape, or form. Gather information around what the boy's suicidal thoughts look like. And that one is going to be a safety. Assess why we're gathering more information about his safety. And inform the boy about a teen group at the agency that would help him develop positive relationships. Educate. Why? Because we're educating them and providing them information on a resource that could help him in some way. Quick review. Social worker, mother, 14-year-old son. Son is deaf. The boy's mother is serving as an interpreter throughout the session. He's finding it difficult to fit in with his peers. He's being bullied at school. He has fleeting thoughts of suicide, previous suicide attempts, and he wants to identify ways to improve his mood and decrease the frequency of his suicidal thoughts. So at this time, we're rule out informing him about a teen group. That could possibly be something in the future, but we just met him, so we're not going to tell him what he needs in his current situation to help improve. At this time, we are going to rule out gathering information around what the boy's suicidal thoughts look like, because we're not going to have him describe the thoughts in front of his mom. He may be uncomfortable doing so because, again, the mom isn't serving as an interpreter for this client throughout the session, and there's no thing that says that he's comfortable doing so. At this time, also going to rule out developing a safety plan. Why? Because ethics overrules every single thing, and our ethical responsibility is to provide an interpreter outside of the family, because we need a professional, because there's no biases, and it makes people feel more comfortable in their situation. So at this time, we're going to provide him information around interpretation services to improve the quality of his services. Ethics over the acronym, because the safety is important, but we need to have him in a safe environment with where he's able to exchange information, because even though other regulations and stuff, if you had to describe your suicidal thoughts and suicide attempts in front of a parent, would you feel comfortable doing so? And would you exchange all of the information that you would otherwise in this situation? So that's how you look at that question in particular. Be careful. Question 8. A hospital social worker meets with a 58-year-old woman and her 60-year-old husband. The woman just had back surgery and states she just wants to go home so that her husband can take care of her. The woman and husband state they do not have any supports in the area, but should be able to manage things on their own. What should the social worker do first to best help the couple? A. Respect the woman's right to self-determination. B. Explore the various resources in the area available to the couple. C. Suggest the couple consider a rehab center until the wife is more independent. D. Validate the woman's feelings around her current situation. And when you have your answer, type one thing that you're blessed to have in your life right now. Opening the polls. 30 more seconds. Slapping the poll shut. The majority think it is B. Second place is D. Third place is A. Fourth place is C. Let's look at it. Hospital social worker, 58-year-old woman, and 60-year-old husband. The woman just had back surgery. She just wants to go home so her husband can take care of her. The woman husband state they do not have any resources or supports in the area, but they feel like they should be able to manage on their own. What should we do first to help the couple? So in this particular situation, we're looking at an application question, why it's a client situation, and we have to react in some way and mobilize and help them and apply our clinical knowledge on what to do. So we will apply the acronym as follows. Respect the woman's right to self-determination. Intervene. Why? Because if we respect her self-determination, it's recognizing what she wants, but it's essentially letting her do what she feels is right in the situation. So lack of action is still inaction. So we had ruled that out. Explore the various resources in the area available to the couple. Assess. Why? Because we're gathering and exploring things with the client so that way it can empower their situation. Suggest the couple consider a rehab center until the wife is more independent at home. Intervene. Why? Because we're providing our opinion to the client in some way, shape, or form, and we are allowing them to decide what they want. Validate the woman's feelings around her current situation. Feelings. Quick review. Hospital social worker, 58-year-old woman, 60-year-old husband. She just had back surgery. She wants to go home. She wants husband to take care of her. They both say they do not have any supports in the area, but they should be able to manage on their own. How do we help both people in the couple? So this is where I make it super tricky and have two different acronym levels. So we have the woman, and then we have the couple. So at this time, since we're working and helping both the couple, D and A are thrown to the wayside because D and A only talk about the woman. So we're focusing on the couple. So our answer has to link back to the question. And that's a site of knowing whether you're reading the question and understanding who is our client or who are our clients in some way. And we're going to rule out C because she says she doesn't want a rehab center. So we're not going to say, maybe you should go to this until you're more independent. Bad moves, bad vibes. We keep our opinions to ourselves. And we need to make sure we listen to our clients and what they want to do. At this time, they say they don't have supports, so we need to help them bridge that gap, fill in the gaps, if you will, and get the job done. That's how you'd look at that question in particular. Both people, aka the couple, is our client, so we have to recognize where the couple is and help bridge that gap. And remember, hospital work is assess, stabilize, and get them the heck out of there. Discharge planning, we need to make sure they have all the resources and information they can do to empower their situation in some way. Question 9. A social worker at a family agency is completing an intake assessment with the 25-year-old man and his 50-year-old husband. The couple would like to gather information to adopt a child since they do not know where to start. The social worker does not support gay couples adopting children since it's never gone well at her agency in the past. What would be the best thing for the social worker to do in this situation? A, seek supervision to work through her current struggles. B, provide information to the couple to help them adopt a child. C, refer the couple to another therapist that can better assist them. D, provide information to the couple around the difficulties in parenting. When you have your answer, type the word Christmas in the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is B. Second place is A and C. Third place is D. Let's look at it. Social worker, family agency, completing an intake assessment, first time visiting with them, 25-year-old man, 50-year-old husband. So they're the client. Couple would like to gather information on how to adopt a child. They don't know where to start. Social worker does not support gay couples adopting children since it's never gone well at their agency. What is the best thing for the social worker to do? A reasoning question, why is an ethical consideration, and we need to respond to the solution, or we otherwise don't know what the heck to do. So A, seek supervision to work through her current struggles. B, provide information to the couple to help them adopt a child. C, refer the couple to another therapist that can better assist them. D, provide information to the couple around the difficulties of parenting. Quick review, family agency, intake, first time meeting them, 25-year-old man, 50-year-old husband. They want to obtain information on how to adopt a child. We don't support gay couples. What do we do? At this given time, we're going to throw D to the wayside because we're not going to provide them information around the difficulties of parenting. That's not what they came here for. And if we're providing that to talk them out of adopting, bad moves, bad vibes, stay in your lane, be an empower, be a mobilizer, and be an enabler. Bad moves. So at this given time, we're not going to refer them to another therapist. Why? They simply are coming in for information and we're doing an intake. So this is the first time meeting them and they're simply requesting information from us. So we're not going to throw them away and say, yup, I can't see you, because that's not something the client's bringing into our agency. That's our own biases and our own ethical dilemma. And we need to set our values, ethics, and morals to the side where a social worker and our own biases are not supposed to be in our clinical practice. So bad moves, bad vibes. So are we going to seek supervision or are we going to provide them information? And at this time, we're not going to just stand up in the middle of the intake and say, yup, I need to seek supervision. Bad moves. They're going to say, where are you going? What do you need what do you need supervision around? We are simply completing an intake assessment and they want information for us. So we need to do our darn job and provide them the information that they're asking. It's not saying we're going to be treating them forever. It's simply they're asking for information. We need to provide the information regardless of how we feel, because if we're restricting clients' behaviors and client treatment based on our own values and ethics, bad moves, bad vibes, you're a social worker. We're not supposed to discriminate based on any social identities and your own biases. Stay in your lane, wear your hat. Your ethics and morals, once you hit the door, are gone. So that's how we'd answer the question in particular. Question 10. Social worker at an outpatient clinic has been working with a 43-year-old man for the past 7 months. who has been struggling with grief around the death of his best friend. The man has been working to help improve his ability to cope and has tried multiple techniques throughout his time in treatment. The man has begun starting to regress and isolate during sessions due to the anniversary of his best friend's death coming up. What should the social worker do to best help the man? A, refer the man to a grief support group to attain more support. B, provide the man a list of positive strategies he can utilize at home to improve his mood. C, work with the man to identify positive strategies to better prepare for the anniversary. D, connect the man with the peer support to better help supplement the man's treatment. And when you have your answer, type one thing that you learned in this session tonight. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is C. Second place is A. Third place is D. Fourth place is B. Let's look at it. Social worker, outpatient clinic, working with a 43-year-old man, 7 months. Any length of time, jump on it. It paints the picture. And we've been helping him with struggling with grieving with the death of his best friend. So he's been working to improve his ability to cope, and he's tried multiple techniques throughout treatment. So he has techniques that he's utilized and they've been effective. The man has begun regressing and isolating during session due to the anniversary coming up. In this particular situation, we are looking at an application question. Why? Client situation, need to react, need to address, need to assess in the most appropriate way. So at this time, we'll utilize the acronym, refer the man to a grief support group to attain more support, refer why we're sending him outside of us, but we're also going to be helping him. And if you notice, grief support group, not a professionally ran group. So we're not going to say it's a facilitate. So we're not connecting them to another professional outside of the agency. It's just another community resource, but he's still going to be working with us in some way. Provide the man a list of positive strategies he can utilize at home to improve his mood. Advocate why key detail utilize at home, not utilize in session, or work with us to do it. Work with the man to identify positive strategies to better prepare for the anniversary. Intervene why we're working with him in some way, shape, or form to get the job done. D, connect the man with the peer support to help supplement the man's treatment. Facilitate why, because a peer support specialist is somebody that is a professional within our agency to help supplement, that has a lived experience that can best help the person in the session. Quick review: outpatient clinic, 43-year-old male. This has been going on for 7 months. He's struggling with grieving around the death of his best friend. He is working to identify positive strategies, and he has used multiple throughout his treatment, which has been 7 months, and he started to regress. What do we need to do? At this given moment, we're going to rule out C, because why would we need to work with him to identify positive strategies? He's been with us for 7 months. He's already identified strategies, and he's been utilizing them for the past 7 months. Why would we give him more strategies if he probably has all the strategies that he needs at this time? So we're also going to rule out B, because again, why give him another list of positive strategies? Because he has 7 months worth of strategies and exercising them and utilizing them in some way, shape, or form. And if you read the question, he's looking for more support. And what better way to get support than to get something outside of us? He's been doing it for 7 months, and he needs more than just us. So if you could refer someone, would you refer them to one person or multiple people, which would come in a form of a grief support group? He's working on grieving. He needs support. So at this time, we're going to throw D out of the way, which is a facilitate. And we are going to refer and send him to a community resource that could better help him. And it doesn't mean that he'll go, but we still have to offer it because we've been working with him for 7 months. He has the strategies and he has all the stuff that he could possibly need. He just needs more support and people around him that have been through the same thing. So that's how we look at that question in particular.